We focus so much on the vaccines and so much on the rollout. Do we forget how much, leaps and strides we're doing in the actual medication to combat the COVID-19 when someone catches it?
Well, good morning from a snowy Baltimore. There is certainly good news all around. Eli Lilly recently had an approval of a dual monoclonal antibody. And so with two different drugs, they're able to lower the dose and eventually, although the trials are still ongoing, possibly shorten the administration time. Right now it's a 60-minute IV infusion. But it is designed to help prevent hospitalization and death in patients with mild or moderate symptoms. So all good news.
Is it good news, Jason, because they could also be more effective in combating mutations or variations of this COVID-19?
So far, it does look like that the broadly neutralizing antibody present in this drug works against the UK variant. I have not seen data thus far about the South Africa variant, but it stands to reason that there would be good support there as well in reducing hospitalization and death.
Jason, when we get through the vaccinations, what people are going to say is what took so long. What is the constraint to beginning to have 50-year-olds get vaccinated? Well,
I think the supply is the ultimate answer to that. Yeah. Right. We have a pent-up demand. Obviously, we have I was on a call with the recent senator here in Baltimore and basically having a conversation with constituents, and the conversation was repeated by every caller, which is, I'm on a list at multiple different locations. I'm over 50 years old. I can't get access to the vaccine.
Exactly.
I've been given no date. Right. So it's about supply. Many people want the vaccine. They just can't get the shot in their arm.
Okay, but Jason, here's the moral question, and I don't expect a religious answer from you, but do you try to cajole over 60-year-olds who really don't want the vaccine, or do you basically say, excuse the French, screw you, and give it to the people dying to have the vaccine in their 40s and their 50s?
Well, I think you raise a really important point, and the problem is that when we think about society and the equity of vaccine access, we are overcoming a lot of vaccine hesitancy among the populations most at risk. So the populations of the African American community, the Latinx community, have greater medical mistrust and other barriers to access care. There's been lots of a historical nature of maltreatment and mistreatment to those populations in the United States. And as such, we actually need to do, and we're planning on doing, a lot of community outreach events and activities to encourage vaccinations among those populations, because there's the disparity in COVID-19, both, morbidity and mortality in those populations. But it does take a lot more work to convince individuals in that community, because of that mistrust, that the vaccine is right for them.
Jason, why are not more countries doing genome sequencing like the UK? You need to understand what we're dealing with, right? So if you have a PCR test, then it can also tell you exactly what the mutations and variations are. Until more countries do that, are we really blind as to whether these vaccines can combat future mutations?
Yes, certainly. Molecular surveillance is quintessential to actually understanding the overall spread of these viruses. California showed that less than 1% at the beginning of January viral variants, and the recent study showed that they were upwards of 4%, a little over 4% by the end of January. So we're actually, driving a little blind here without more molecular surveillance. And what that would obviously do is tell us how many people have each variant, where those variants are most likely to spread, and help us to, further mitigate their spread by, increasing measures necessary to prevent transmission.